Hello, my name's Dr. Amali Lokigamage, and I'm a consultant obstetrician and gynecologist, and I'm also an honorary associate professor. My pronouns are she and her. I've done a great deal of work in health equity and in particular decolonisation. In this short presentation, I want to convey to you three areas. The first area is what intersectionality is. The second is why it matters. The third is how taking an intersectional approach involves co-production with people with lived experience of overlapping layers of oppression, and how this is vital for equitable policy formation and implementation. So in this first section of what intersectionality is, I have to mention the person who coined the term. And this was Professor Kimberly Crenshaw, who coined it in the 1980s. She worked at UCL Law, was an expert in critical race theory, and she was a black feminist. And her work sort of highlighted that the experiences of black women who faced discrimination was based on both race and gender, and that in, for instance, the US, that traditional anti-discrimination laws didn't address the sort of specific challenges faced by black women as opposed to, for instance, black men. Intersectionality holds a lens for examining the study of the social determinants of health, and it has the aim of reducing healthcare disparities and promoting social justice and health equity. Intersectionality is a framework for understanding how our social identities like gender, caste, sex, race, ethnicity, class, sexuality, religion, disability, age, weight, physical appearance may overlap and intertwine to create a unique experience of either privilege or oppression. And without examining this, we cannot gain a nuanced understanding of social inequalities. And in the second section about why it matters, we have to establish that intersectionality helps us to really excavate the root causes of social inequality, and it therefore really aids in developing inclusive social justice movements and helps us create policies that address the needs of all people. And by understanding this intersectional nature of social identities, we can work more specifically at dismantling systems of oppression and ultimately creating a world where everyone has the opportunity to thrive. In the last point, I've mentioned that it's more rhizomatic than social determinants of health. And the term rhizomatic comes from decolonial thought, where solutions are found in a kind of organic manner, not in a kind of hierarchical top-down structure. And this is where using co-production is essential, because the voices of those oppressed can create unexpected solutions which are unimaginable to the institutional hierarchy. The botanical metaphor of a rhizome is like an underground tuber, a type of root that branches in unexpected directions and finds ways around obstructions. So there is more dynamism in this intersectional lens. So intersectionality asks us to avoid analytic systems that treat each axis of oppression in isolation. It invites a more complex understanding of interweaving oppressions that people face when they experience prejudice in society. There are criticisms about intersectionality in that some people say it's somewhat ambiguous, and that intersectionality sometimes reduces individuals to specific demographic factors and lacks defined goals. But nevertheless, it is a powerful tool if you want to promote social and political egalitarianism. When using it as a tool for healthcare management, research and policy making, you should engage intersectionality as a sort of guiding, conceptual, methodological, praxis-orientated framework which can help you focus on power dynamics, specifically the relationships between oppression and privilege that are part of society. And you can then gain an opportunity to reframe existing conceptualizations of power in order to work effectively with community organizations and global social movements. And you also have the opportunity to excavate the way in which a person's multiple identities and social positions are embedded within a whole system of inequality, and furthermore, expanding out to the macro view, it looks at the need to link individual, institutional and structural levels of power in a given socio-historical context for advancing healthcare equity. And this is where I often bring in some of my understanding of decolonisation, because that gives you a way of examining the way in which healthcare was actually set up originally and the biases and privileges that linger within it. We come to the third part of the talk in terms of policy and how to adopt an intersectional approach, and break it down to 4 areas: policy advocacy, challenging assumptions, co-production, and structural or institutional reflexivity. The last part I will elaborate further in future slides. So when you have policy advocacy, you have to bring to the table activists, healthcare staff, academics, policymakers, and use the intersectional approach to advocate for policies that address the unique needs of marginalised communities, but helps all of society ultimately. When making a policy, you've got to challenge assumptions by considering intersectional identities, and we avoid policies that lump one type of oppressed group together in an unnuanced way. So to do this, you need to engage with people with lived experience of societal oppression and co-produce policies. And these people will point out the blind spots in non-intersectional policies. This whole practice of using grassroots input to improve healthcare policy involves structural and institutional reflexivity. What I mean when I talk about reflexivity is that institutions and members of the leadership teams and clinical staff need to examine their feelings, their reactions, their motives on how they influence healthcare and what they think or do in any given situation. For instance, if we look at racism in maternity care, you would have to look at reflexivity around institutional assessments of power imbalances that exist in services, and you should react to circumstances as they happen, looking inwardly and outwardly in a social context. So if you were developing, say, a guideline in maternity, you would have to acknowledge race as a social construct, that racism is a determinant of health, and acknowledge that, for instance, old cohort data did not adjust for the experience of racism. So you would have to take an intersectional approach to the oppressions that the data would reveal, and use the lived experiences of women from, for instance, in the case of the disproportionate mortality of Black and brown women in maternity care. You would use the voices of women from ethnic minorities and birthing people within the maternity system, and you would co-produce a service, a policy, a guideline, or research. Remember, I referred to the socio-historical structures within healthcare and being reflexive around it. So that is why I would apply a decolonial lens to intersectionality, because it too is engaged with dismantling ingrained historical oppressions in healthcare delivery and policy. It challenges even the education that healthcare providers receive, whether they're nursing staff, midwifery staff, all other allied professionals, medical professionals, managers, in how they are educated, and avoiding the hidden biases and prejudices of the hidden curriculum in healthcare, which is where biases are transmitted in unwritten ways that are not in the official curriculum, but are nevertheless transmitted because of how the subjects we choose to educate people in and the subjects we avoid education in. And that is why I felt that using a cultural safety model, which is a decolonizing model of anti-racism, is very important, rather than cultural competence, which never actually developed a strong evidence base. And cultural safety holds the interesting position of being evolved by people who were colonially oppressed, rather than policymakers, academics deciding on what cultural competence is. And so cultural safety counters that criticism that intersectionality has of reducing the individuals to specific demographic factors and lacking defined goals when you perhaps utilize the cultural safety model. And cultural safety uses co-production at all levels of healthcare, all the way from patients to staffing to institutional policies. I mean, there's much more to add, but as we're focusing on intersectionality, these are the points I want to convey in this presentation. This infographic called the Cultural Safety Tree, in a publication called Translating Cultural Safety to the UK, is a way of simplifying the tenets of cultural safety. It uses the metaphor of a tree, and there are three strands stretching from the roots up the trunk into the leaves, branches and flowers. And at the roots are the principles of person-centered care, staff self-reflexivity and structural reflexivity. And then along the trunk, this leads upwards through nurturing principles, healthcare, human rights, and institutional commitment to reviewing structural knowledge and biases. There is a table form of the very same information for those who are not visual learners, and this comes from the same publication, which might help some people. I won't sidetrack you further with cultural safety, but have to mention that the framework was developed by a nurse educator who was a Maori in New Zealand, and her name was Irihapati Ramsden. I'm going to summarize what I've tried to convey to you in this talk, and that was essentially what intersectionality is, why it matters, and how taking an intersectional approach and working with people with lived experience, with overlapping layers of discrimination and oppression, can help develop equitable policy formation. Thank you very much.